Hi guys. Hope you had a good weekend. I've put myself under pressure today because I'm actually on the school run, and I've really got to go and pick up both my sons in the next 4 minutes. But I've got enough time to go through one question which I had after the cannula video, which was which is better for tear trough, because I mentioned basically using both needle and cannula for doing tear trough. And so the question is, what's actually better, which is a really great question because it's a complex answer. So the benefit of cannula, as we know, is to reduce the chance, in particular in the tear trough, it's about reducing the chance of bruising. And reducing the chance of bruising is a huge benefit when you're treating the tear trough, because the social impact of having a bruise is quite significant, because bruising around your eye is associated with lots of things that people don't want people to think of them. So usually it's kind of, I've been hit by someone, or I've got too drunk and fallen over. So we can't underestimate what it means to people to walk around with a bruise. It makes them very unhappy. And if you can reduce the chance of it, we should definitely do that. So that's firstly why cannula comes into the equation, because you can reduce bruising. Now, lots of people do worry about blindness as a risk with tear trough. It's actually statistically not one of those treatments that's particularly highly associated with blindness. Highest risk is treating your frown line or glabella. Noses are also a big risk. Tear trough really isn't, just because the blood vessel isn't actually, the angular artery isn't that close if you do it in the normal way. So you can treat tear trough without having that being like the number one risk, but all patients seem to think that it is. So cannula is often also why that conversation comes up. So why would you use a needle to treat a tear trough when there's bruising? Well, the main thing is with a cannula, it's quite difficult to get deep. So as a rule of thumb, something which I've always thought, and then actually Maurizio De Maia said it to me last time when we were doing this, my first lot of training with him, always think of cannula as being in the fat. Now you can try and get really down deep and scrape along the periosteum. It's pretty uncomfortable and it's difficult, and you're probably still not quite as deep as you would be with a needle. And therein lies the big difference, which is if you're using a needle, you can get onto periosteum, and that means you can hide this filler really deep underneath all the other tissue, and the only thing, it just sits on the bone with a fat on top of it. As soon as you start using a cannula, you're mixing filler and fat, and I think in particular people that becomes a bit mobile. It attracts a bit of moisture. As the eye moves up and down, it can change position a bit more easily, and the biggest factor is moisture attraction. There are only two fillers I think you should be using in the tear trough. One is Juvederm Volbella, and the other one is Teosyl Redensity 2. So both of those are well established for using in the tear trough. Now, people use all sorts of other things as well, and you might be getting great results, and that's fine. And please, be interested to hear them. But I think a bit of manufacturer backing is quite a good idea when you're doing something like the tear trough. So that's what I recommend is, understanding that difference. So if your issue, this is another really subtle difference with tear trough. Some people have a tear trough that is partly caused by actually the fat bulges out, the ligament holds the tear trough, holds the tissue around there in place, and it looks like a shadow, but actually you've got a little bit of bulge from the fat. And that's going to be a lot harder to treat, and you definitely should not be putting a cannula into those people, because you're much more likely to be adding to the problem of fat. You can, in some people, blend in that transition, but I would be using a needle in those cases so that I'm really down deep, elevating the ligament almost, and trying not to involve any filler with fat. You start with time. I always didn't fully was with needles for years, never did anything except needles. And then I was trained with cannula. I thought, this is amazing, I want to do cannula. And then I started to get people coming back with little bits of puffiness. And I've over time started to get better at predicting who those people are, because I still prefer cannula. I just don't do it on everyone. And I think the rates are better, but I'm looking for those kind of puffy, slightly puffy lower lids. I mean, talking slight, because very puffy lids, you're not going to do it anyway. Slightly puffy, a sense of a fullness rather than just emptiness. Those people I'm erring towards, let's hide this filler further away, rather than if it's just clearly lost volume and you can blend that in nicely with some Volbella, then it will probably work quite well and quite safely. So it's difficult to really pin down exactly in words, because it's kind of an instinct you get after treating many people and seeing a few people come back, and it's a well-known side effect. There's a little bit of puffiness after treatment, and we're always in this battle to try and reduce that and get that down to zero. So that's my thought process. Look for true pure volume loss, a bit easier with the cannula to say yes, it's the right instrument. And then anything where there's a sense that the fat might be moving quite a lot as their eyes are moving, or a little bit of fullness, you want to maybe towards a needle. And you should get slightly fewer people coming back. By far the biggest variable is product, because in the years gone by when we first started doing tear trough, I was taught with fillers that now I wouldn't dream of using. So they basically attract moisture. We were always taught to undertreat, and it would hopefully expand to just the right amount, which I could do sometimes, but it was kind of 1 in 25 people, you'd have a little bit of a problem. And it wasn't always immediate. It could be 6, 8, 12 months later. And definitely the new products are way, way better. So choose your product correctly. Start to think about needle versus cannula, and the ones who come back. You will learn from the people who unfortunately do need a reversal or a massage. I'll do another talk on how to deal with it, because you don't always have to reverse it. Because I'm pretty sure my wife's going to come out that door any second and say, we're late to pick up the boys. She's in a meeting, and I think she's probably forgotten. I might have to go knock on her door. But I hope that helped. That's how I choose between needle and cannula. Any other questions, please? Loving the questions coming through. You can comment on this thread. You can inbox me. You can email me at tim@drtimpierce.com. And I'll try and, we're going to try and do more of these and make them a bit better produced over time. But at the moment, it's just about being regular. So I'm pleased I managed to squeeze this in before I go on the school run. Thanks for watching. If you think anyone else might be interested in this, if you tag them on the post, that'd be great. Or if you think it's useful to other people and you want to share it, that'd be amazing. So thanks very much for watching. I'll catch you again probably tomorrow. It will be tomorrow. We'll do another one. Thanks, guys.